Welcome to the November 7th, 2024 Talk with the Doc with Dr. Timothy Leichliter of Allegheny Health Network. Thank you everyone for joining, and please take it away, Dr. Leichliter.
Thank you, Casey. I know it doesn't look like November out there. That's for sure. Hard to believe it's already November. All right. Well, welcome to the party, everybody. If you've been here before, you know what to expect. If you have not been here before, welcome. I am Dr. Leichliter. I am a movement disorder specialist, neurologist, sitting here in my office at Allegheny General Hospital. We are now in the back of the hospital. Used to be on the front of the hospital. Now I'm in the back. And I'm going to answer your questions. So if you have questions, I have some in the emails that I'll start with. And then if you guys have more questions, type them in the chat box down there. At least for me, it's on the lower right. That's where I'll go to after I answer all the email questions. As I like to caution people, again, everything you hear is my opinion. I have a lot of opinions. I will tell you all of my opinions. I like to think my opinions are based on as much medical fact as I can come up with, but sometimes I do make stuff up, and I will let you know when I do so. And because this is my opinion, you may go to somebody else and they have a different opinion. Again, welcome to the world. We all have different opinions. But I'll give you the best information I can come up with. If you're my patient, this is what I would tell you in the office. And if you're not my patient, well, this is what I'll tell you now. I am drinking some green tea here. It's supposed to be healthy. We'll see how it goes. All right. Is there an official test to determine if you have Parkinson's? No. No is the short answer. So generally, even today, Parkinson's disease is still a clinical diagnosis. And so the long story short is I am the test for Parkinson's disease. I tell you have Parkinson's disease, you take my word for it. Or I tell you don't, and you take my word for it. And at least today, it's still based on the clinical diagnosis. So it's based on slowness of movement or bradykinesia. You have to have some tremors or some stiffness or some other symptoms, and they have to be there for so long, and it has to fit a clinical picture. You will hear more and more about tests for Parkinson's disease because we keep coming out with more and more tests that are becoming more and more readily available. The DAT scan is the one that's been around for a while now. I'm not even sure how long it's been around, but it's been around for a while. This is a nuclear medicine scan that I can fluoresce your deeper structures in your brain and make them shine nice and bright or not so nice and bright. Likewise, there is a skin biopsy test, which we've started doing here a couple of times, looking for misfolded or phosphorylated alpha-synuclein, which is the protein we think is part of the problem along the pathway in Parkinson's disease. And likewise, I think about a year ago, really big news through the Michael J. Fox Foundation was that through some spinal fluid, we could also test for alpha-synuclein. None of these tests are specific for Parkinson's disease. And so what I mean by that is they can all tell me that I'm in the right ballpark. They can all tell me that you have an alpha-synuclein or a protein misfolding problem, or that you have a dopamine problem, but none of them are specific to say this is definitively Parkinson's disease versus this is progressive supranuclear palsy or Lewy body disease or multiple systems atrophy or other Parkinson's-like conditions. And so realistically, I do not do those tests for everybody. I do them when I'm trying to answer a specific question, when I'm really confused about what the diagnosis is, and it's really important that know that I'm in the right ballpark. So I've done a couple of skin biopsies for people that I was thinking about sending for deep brain stimulator surgery, mainly to try to figure out which target in the brain are we going to aim at. So that's a specific reason that I'm ordering that test to answer a specific question that is going to dictate what we do for that person. I don't need those tests in the general population. If you come in with tremors and stiffness and look like you have Parkinson's symptoms, I don't need a test to tell me I'm in the right ballpark. I'm fairly confident I'm in the right ballpark. But there is a specific time and place for ordering all of those tests. Although I haven't ordered any of the spinal fluid tests yet. I'm not sure I know how to get that around here, but the other ones I have done some of. And so the long story short is Parkinson's disease is still a clinical diagnosis. You still get it from somebody like me based on your symptoms, based on your progression, based on your response to medicine. And yes, we are working on some of these ancillary or other tests, and at some point they may very well be useful and available more frequently and easier to get. But for now, they're just sort of ancillary tests that I use in the appropriate patient. Which leads me to what are the atypical Parkinsonisms? And then the second part of the question is ALS considered an atypical Parkinson's? ALS is not usually considered an atypical Parkinson's disease variant. It is a completely different neuromuscular disorder that has completely different symptoms. There's some overlapping similarities, But at the end of the day, they are very two different pathological neurological diseases. And so ALS, I don't typically consider ALS or Lou Gehrig's disease as a Parkinsonism. It can have some tremors, it can have some stiffness, it can have some walking problems, but usually it's more of a neuromuscular, a weakness problem. Your motor nerves aren't firing correctly. But there are a few atypical Parkinsonisms, and so there's a couple different varieties of Parkinsonism. So there's Parkinsonism or Parkinson's symptoms caused by something else. So probably the most common cause of Parkinsonism is medication induced. So medications that we use for disorders like bipolar disorder, schizophrenia, or even severe anxiety and depression, medicines that can block dopamine can give you Parkinson's symptoms. And then there's a couple of medicines that we use for nausea that can also block dopamine that can give you Parkinson's symptoms. So drug-induced or medication-induced Parkinsonism is probably the most common cause. There's also something called vascular Parkinsonism, where if I look at an MRI scan, I see a lot of vascular or white matter changes, white spots showing up on the MRI. And that can lead to Parkinson's symptoms, usually more walking and balance problems, difficulty with gait more so than typical tremors and stiffness. And then there's the Parkinson's plus conditions. So the Parkinson's plus conditions are progressive supranuclear palsy, multiple systems atrophy, corticobasal syndrome, and Lewy body disease. These are the four typical Parkinson's plus conditions. And they can all start off looking very much like Parkinson's disease, but then they start getting other symptoms to go along with it, hence the plus. And they're more or less a Parkinsonism, not a true Parkinson's disease. And then there's everybody else. So when I'm labeling somebody with Parkinson's disease specifically, I use that for a specific reason. I will use that in a typical patient, typical age of onset, typical presenting symptoms, typical rate of progression, typical response to medicine. If any of those things are atypical, meaning you're just progressing a little bit too quickly, you're not responding as well to the medicines as we would like, I will probably label you as Parkinsonism, not Parkinson's disease. And the reason for that is really one reason. If I think somebody has true Parkinson's disease, I have a really good idea in my head what's going to happen. I have a fairly concrete or good idea how you're going to show up to my office, how you're going to respond if and when I put you on medicine, how you're going to progress, and how quickly it's going to take for things to happen. And I kind of have an idea, a fairly good idea of how your trajectory or how your pathway with the disease is going to go. If you don't fit that perfect category, if you're a little bit atypical, you're a little bit younger than typical, you're a little bit older than typical, maybe you do have some vascular changes, maybe you're not responding to the medicines the way that I would like, I am much less confident that I know what's going to happen. And so that's the distinction for me when I'm trying to decide, does somebody have Parkinson's disease, Parkinsonism? How are we, labeling things like that? That's kind of where I leave that at. And so it's really not a big deal. What I do or how I treat things or the recommendations of exercise and therapy is all going to be the same for the most part. But it really comes to predicting or suggesting to you guys what to expect. That's really the distinction in how I use it. And likewise, the third question on this page was, what are some people diagnosed with Parkinsonism before Parkinson's disease? And so again, at the end of the day, that those are the two main words you'll hear. Parkinsonism is anybody who comes with those symptoms. So if you have tremors and stiffness and slowness of movement and balance problems, you have Parkinsonism. Parkinson's disease happens to be the most common cause of Parkinsonism, and that's everything that I just talked about. And so that's where and again, I may do that a little bit differently than your doctor does, or than your neurologist does, or than your primary care doctor does. But that doesn't mean necessarily any of us are wrong. It's just I have a fairly strict way that I use these words, and other people might not. Believe me, I've gotten plenty of patients referred to me as Parkinson's disease that then they come to my office and I'm like, well, maybe. Maybe this is a little bit atypical. Maybe this is Parkinsonism. And that's okay. And we have this conversation. It doesn't change what's going on. It doesn't change what we do. It doesn't change a whole lot. It's just a wording that we'll use to try to explain what we're dealing with. All right. So the next question was regarding stomach pain, feeling tight and rigid, and they wanted to ask if this could be a form of Parkinson's hidden tremor, internal tremor. Maybe. So when we think about Parkinson's disease, there's the outwardly visible or obvious symptoms, the tremors, the slowness of movement, the shuffling gait, the decreased arm swing, the not a lot of blinking, but there's a whole lot of internal things that we can't see. And actually, tremor can be one of them. So I get a lot of patients that come in and say, you know what, I just feel like I'm shaking on the inside or I'm shivering on the inside. Even though looking at them, you can't see any tremor. That's more or less an internal tremor. And likewise, you can get abdominal stiffness or tightness, or you can get spasms or cramping or muscle contractions that I can't see or feel. Again, I can feel your arms and legs, but I can't feel your, abdominal muscles or even neck muscles are difficult. And so there are symptoms that are not visible to the naked eye. So it's possible. I mean, if you're having a lot of stomach pain, if you're having a lot of cramping or contractions, it could, or internal or shaking, or, kind of like you're shivering or cold on the inside. I mean, those could all be Parkinson's symptoms. Um, they're not always, and so you kind of have to try to see, does it correlate with medicine? Does it go with your other symptoms? Does it respond to things? Is there a pattern to it? I mean, these are all the things that I would ask to try to help tease out that answer. And likewise, you can treat, internal tremor or stiffness with the same medicines I use for external or outwardly tremor. And oftentimes they do respond. And then the other part of this question was, why exercises like boxing or stretching or any form of exercise help with Parkinson's disease? And that's a much more difficult question. If you've listened to me talk, you know that exercise is my absolute favorite topic of conversation because it really is, in my opinion, the best medicine and treatment for people with Parkinson's disease. It's the only thing we think could or is or will potentially be disease modifying, at least at this point. We're fairly confident that the pills that we use, the medicines that we use, the surgeries that we do treat the symptoms, but are not actually impacting or slowing down the disease. Exercise we think might. That's not exactly proven. There are studies to suggest it's accurate, but it's not completely proven. But in my opinion, it does. Exercise really does, in my experience, help people stay better longer. The people that come to me exercising the most are the ones that do the best, and the ones that I can't convince to exercise are the ones that do the worst. And so I really do think there is a disease modifying property to exercise. And exercise comes in infinity different varieties, and none of them they really haven't. There's been a couple of posters and maybe some small papers comparing them head to head, but they really haven't been compared head to head. And all exercise is good exercise. Now, how does it work? That's a much more difficult question, and I don't know the answer to that question. There's a lot of theories out there. It could just be that it makes your muscles and bones stronger and mechanically you do better. It could be that it helps your cardiovascular system build up endurance and you're able to do more. It could be that it actually helps prevent cell breakdown. It could be that it helps clear cellular debris and helps cellular mechanisms at the micro level work better. It could be that it helps your mitochondria function better, which are the powerhouse components of the cells that we know are impacted in Parkinson's disease. It could be that it's anti-inflammatory or helps with kind of free radical scavengers, much like your antioxidants do that you take over the counter. It could be all of the above. It could be none of the above. I don't really know. And at the end of the day, I don't really care either. Somebody cares, and it would be nice to replicate. In fact, there was a talk on this actually at the Movement Disorder Society where they came up with an actual chemical that they thought was the working chemical or the end result of exercise. But I haven't seen that replicated. I haven't seen that put into production yet. I keep waiting for a pill that replicates exercise. Hasn't happened yet. And so the short answer to that question is I don't really know how exercise works or why it's beneficial. I just know that it is, and you have to do it. And then the last question on this page was are about antidepressants and if they help with people with Parkinson's disease. And the answer is yes. So they've actually done some studies in the antidepressants that we typically use for anybody who comes in with anxiety and depression. And they actually checked them in people with Parkinson's disease, and they do indeed work. And we do know that Parkinson's disease comes at least 50% of the time, although I feel like that is a significant underestimate with anxiety and depression. I feel like it's probably closer to 75%, or if you really got down to it, closer to 100% most likely at some level. And we do use a lot of the same antidepressants and anti-anxiety medicines that we use for everybody else, and they do tend to work. And so the short answer to that question is yes. A lot of the medicines that we use for your average person who comes in with depression and anxiety are the same medicines that we use for you people, and we still get the same benefit. And which is important because we also know that if you ignore things like anxiety and depression, people do significantly worse. And so it is something that you have to bring it up. It is something that we have to talk about, and it is something that we have to treat if it's a problem. And it is something that, yes, you may indeed need to see a psychiatrist for. Nobody likes it when I tell them they need to see a psychiatrist, but at the end of the day, nobody hesitates to come to me because I'm the specialist in Parkinson's disease. Why would you hesitate to go to the people who specialize in anxiety and depression? That's the best way to think about it. But the short answer is it is something you have to treat and you can't ignore it. And then I think I got one more question in here. Oh, right. So I thought I've had this question before, but it's worth reiterating because it is flu season and winter season. And so I bet a lot of people are running into this. I got my COVID shot yesterday. And up until 2023 shots, I only had minor pain at the injection site. 23, 24 actually had neurological reactions, increased tremors in hands and face, weakness in arms and legs, difficulty standing from a seated position, and sleepiness. Is there any research or anecdotal evidence about the effect of the latest COVID shots in Parkinson's patients? So far, still a COVID virgin, hadn't gotten COVID yet, so getting the shots on a regular basis are important. And the effects that he mentioned, or they mentioned, usually last 2 to 3 days. So a couple things about this. This was actually talked about at the Movement Disorder Society meeting as well, where the vaccines really are important for people with Parkinson's disease, in terms of limiting this, because we know that COVID can be one of those hits in the multi-hit model that leads to the development or progression of Parkinson's disease. And the vaccines, at least some of them, tend to help mitigate that hit. I've gotten about, I don't even know how many shots I've gotten, 5 or 6 shots, however many, whatever the number of shots you were supposed to have gotten, I've gotten. And every single time I get the shot, I have a day of fevers, chills, soreness, aches, almost like I have the flu. I don't have Parkinson's disease as far as I know. So the short answer is these kind of things can happen to anybody. I don't know that it's ever been researched or there's been any papers on this, but I myself have had plenty of patients tell me that yes, when they get the shot, their symptoms get worse. Sometimes usually temporarily or transiently, but I've had patients come in and say, you know what, I didn't bounce back as well as I was before I got the shot. And I still tell people in general, unless you get significantly worse or have a significant reaction to it, you are much better off getting the vaccine than you are getting the disease. COVID itself definitely makes things worse. And so anything you can do to mitigate that risk is going to be helpful. And so if you have a couple of days of worsening symptoms, but you know this happens a couple of times and it gets better, I would still suggest getting the shot. Likewise, if you don't have any reactions, I would still get your vaccines. I would get your flu shot too. But, at the end of the day, you got to pick and choose what you want to do. But only because, again, COVID has been shown to be something that can trigger Parkinson's disease, worsen Parkinson's disease. In fact, the lecture that I was sitting to suggested that we still haven't even hit the peak COVID inducing or producing Parkinson's disease, and that's expected in the next 5 to 7 years, where they expect to see a wave of people with Parkinson's disease or Parkinson's symptoms coming from the COVID pandemic. Again, we don't know, more to come. We will see. But at the end of the day, yes, I get a lot of patients who tell me that not only getting the COVID, but getting the vaccine does trigger the symptoms. And realistically, unless you have a severe reaction or some good reason why you shouldn't get it, I would definitely recommend you keep getting your vaccine. All right. Those were the only ones I had in the email. So let me go to the chat box here and see what I can come up with. Can I take cyclobenzaprine, which is Flexeril, with Mirapex? Sure. You can do whatever you want. I can do whatever I want. We can do whatever we want. The short answer is yes. I mean, I use muscle relaxers, which is what Flexeril is in my patients, not every time, but not infrequently. And yes, Mirapex, again, I use fairly frequently, and I use the combination not infrequently. Again, your biggest risk is going to be side effects. Again, muscle relaxers are going to make you tired. Pramipexole or Mirapex can make you tired. There is an additive effect of side effects when you start mixing medications, but the short answer is yes, you can mix these medicines. You just have to be careful. And much like everything else that we do in the office, it's going to be trial and error. And that's just something you're going to have to deal with. iPad 102, you have a question? I don't know, they put up their hand. All right, iPad 102, we will come back to you.
The question is, do you have an opinion about milk or yogurt making, or cheese making Parkinson's worse?
Sure. I have an opinion on everything. Of course I do. And my short answer is maybe. Again, my opinions are usually vague and well controlled. But so the long question that you're asking is there some evidence to suggest that dairy products are bad for people with Parkinson's disease? This goes back probably a couple of years now. There was a paper written or a couple of papers written about dairy products and how it correlates with progression or people having worsening Parkinson's symptoms. I've never seen that reproduced, and there's not a lot of research into diet and specific dietary things, and that's probably part of the problem. There's a whole lot of research aimed at medications, as you guys are well aware of, but also exercise, but it's really hard to actually study diet. You're really relying on people keeping diaries or patient-reported outcomes. No offense to you patients, but your guys' memories aren't exactly as good as could be. And so you end up running into a lot of biases when you're actually trying to study diet and its effect on disease processes. And this is why it's really hard to study. I don't think there's enough true evidence out there to suggest that people who eat more dairy products or drink milk tend to have a worsening disease progression or a much quicker progression. That has not been my experience in my office clinic. And so I am not one who tells people that they have to stop eating their cheese or stop drinking their milk or stop eating their yogurt if you like those things. Again, if you don't like those things, I don't think you have to go out of your way to start eating or drinking those things. I don't think there's any evidence to suggest it's beneficial or helpful, but I also don't think the evidence to suggest it's not good for you is good enough for me to say, yes, you have to make some dietary changes. There may be more to come on that. Again, there's a lot of people try to look at a lot of these things, but they're really hard to study. And so that's kind of my opinion on that. Any thoughts on vibration balls? The vibration glove. I'm still waiting to get my hands on these things. I know they're commercially available and I've seen them before, but I've never actually played with them. I've never actually had somebody come back in and say, hey, this is what I did and it worked. So there are balls that you hold on to that vibrate that theoretically, if you hold on to them or do these things for a while, it controls your Parkinson's symptoms for a while. And there's gloves that have the same thing. I think the ones that really triggered everybody's attention and opinion was when it was on the Today Show from Stanford, and how they showed these videos of people wearing these gloves, and then all of a sudden they were normal. Again, I am a skeptic at nature. You might say I'm pessimistic at nature. You're probably not wrong. And so at the end of the day, I believe it when I see it. There's a lot of advertisements out there for these things. You can buy them. The evidence is kind of questionable in terms of actual good, hard research trials proving these things work. Even the one that was on the Today Show was just starting research trials over in Stanford. So we're still a couple of years away from getting information about that. But I have a hard time finding good evidence to suggest that these things are really good. Now, on the other hand, they're probably low risk. I don't know how much any of them cost, but I can't imagine that they're harmful to you. And so if you want to try them and you want to pick them up and you want to play with them and you want to see if they work, knock yourself out. Please do. And if you're my patient, come back and tell me what happens. Then I'll have a better answer for this. But at the end of the day, I haven't played with them myself. I haven't had patients come back and say, I tried this and this really worked. I've seen the videos, I've read the online kind of testimonials, but there's not a lot of good, hard, fast, research proven evidence. And so again, I'm gonna believe it when I see it. What is a DAT? Excuse me. What does a DAT scan prove? That's a good question since I talked about it earlier. So a DAT scan is a nuclear medicine scan. It's a dopamine transporter scan. So when your dopamine is released from your first nerve to send that chemical to your second nerve to do what you want it to do, which is move or do other things, not all of that dopamine gets stuck to the second nerve. But your brain and your body are also pretty good at conserving things. They don't like to reproduce things if they don't have to. So that dopamine then gets recycled. When that dopamine gets recycled, it has to go through a transporter to get back into the nerve, and that's what a dopamine transporter is. And we think that dopamine transporter is a surrogate marker of how many dopamine producing cells you have and how much dopamine you have in your brain at any given time. We can't measure dopamine, at least not well. You will get tests that test for dopamine and give you a number, but that number doesn't mean anything because we don't have good definitive tests. We don't know what normal is. Dopamine levels fluctuate based on about 10,000 different things. And so you could tell me my dopamine level is this, and I won't have any idea what to do with it because I have no idea what it was supposed to be at that time, in that setting, with that mood, with that sleep, with that medication. And so dopamine levels, which you can get tested, are really not useful to me at all. We don't have good ways to measure dopamine directly. Indirectly, we use the dopamine transporter as a surrogate to tell us that we think you have lost cells that produce dopamine, or you have a dopamine deficiency. And so we can radio label that dopamine transporter. We can put you in a nuclear medicine scan, and then it fluoresces. Normally, it fluoresces nice bright white and pink. It's symmetrical. But in people with Parkinsonism or Parkinson's disease, it's not as bright. Usually it's asymmetrical. One side's worse than the other. And that's what we see when we do a DAT scan. So a DAT scan tells me that you have a dopamine problem. It doesn't tell me that it's specifically Parkinson's disease, but at least lets me know we're in the right ballpark. It was initially invented to tell the difference between Parkinson's disease and essential tremor. Now, I don't really need a test for that, and I very rarely do a DAT scan to answer that question. I will do a DAT scan in somebody who looks like they have Parkinson's disease, but they're not really responding very well to medication. Because at the end of the day, the question is going to be, are you not responding to medication because I'm wrong, and this is not Parkinson's disease, and this is not a dopamine problem, and I need to think about other chemicals, or is it because I just haven't given you enough medicine? And that's where I'll use a DAT scan. If a DAT scan comes back as positive, suggesting that you do have a dopamine deficiency, then I know maybe I just didn't give you enough medicine and I need to ramp up the dosages or layer in a couple different medicines. If I do a DAT scan and it's normal, meaning you are not having a dopamine problem, that's when I need to rethink and maybe switch to a different chemical. So that's where I'll use a DAT scan, and that's what it quote unquote proves. But it doesn't really prove anything. It just gives me more information about what's going on in terms of dopamine levels in your brain. I have body aches that keep me awake or prevent me from getting back to sleep. It feels like flu, but it isn't. Is this common for Parkinson's disease patients? And I would say probably. Pain of all sorts are common in Parkinson's disease, not just in the back, but everywhere. And there's a bunch of different varieties of pain in people with Parkinson's disease. But I would say that story is pretty common. I hear a lot of people that say, I wake up in the middle of the night and I'm sore, or I'm stiff, or I can't go back to sleep. And probably the first thing I do is I look at their medicines. And oftentimes what I find is, hey, this person's on pills every 4 hours when they're awake, or every 3 hours when they're awake. And sure enough, 3 to 4 hours after they go to bed, that's when they wake up. And so even though you're not burning as much dopamine when you're sleeping, pills do still wear off. And so it's not uncommon for that wearing off when you're asleep to wake you up, make it harder to get back to sleep, make you stiff, make you have pain. So that would be the first place I would look. But also, there's a whole bunch of other reasons why you can have pain, and pain oftentimes keep people awake or prevent them from getting back to sleep. It could be a structural problem. It could be a dystonia, meaning maybe you need more medicine, even not necessarily in the wearing off setting. It could be that you have a different problem. And these are all things that we'd have to try to tease out. But paying attention to how, is there a specific time pattern to it? Is there a relationship to your medicines? Do you always wake up at the same time? And is it in any way, shape, or form when you would normally wear off in the night or in the day? I mean, these would be the places I would probably start. But yeah, the short answer is I get a lot of complaints about pain, stiffness, soreness, difficulty getting back to sleep in the middle of the night, things like that. That's not that uncommon. He is concerned his UTI has not been cleared up before he has been prescribed more medication. I mean, at the end of the day, urinary tract infections are a huge challenge for me. Urinary tract infections make everything worse. Now, the hard part here is, so you might say, well, okay, treat the urinary tract infection, see what happens. Great idea. I agree. It's not always that easy, though. And I get a lot of patients who have recurrent urinary tract infections. Because the bladder can also be impacted in Parkinson's disease, decreased bladder emptying, frequency, urgency, a lot of things. It's difficult to tell, A, when somebody has a urinary tract infection, and B, is it cleared? Are you just colonized with bacteria and it's not a true infection? These are not always straightforward and easy questions to answer. Obviously, in the ideal setting, if my patient calls me up and says I'm significantly worse all of a sudden, and the first place I'm going to check is urine, because 9 times out of 10 it's a urinary tract infection. And if there's an infection, I'm going to try to, well, I'm not very good at treating urinary tract infections, but I'm going to ask somebody who is to figure out how to treat your urinary tract infection. And I'm going to try to hold off on giving you more medicine. I'm going to say, let's wait and see how you do clearing the infection. And then if you still need more medicine after that, we can think about it. But then it gets tricky. How long do you wait? How do you know if the urinary tract infection is cleared? A lot of my patients end up with chronic or recurrent or repeated urinary tract infections. And so then we're constantly chasing urinary tract infections. And so that's not an easy question to answer. I mean, yes, in the ideal setting, we would say, let's wait until the UTI is cleared. And then if you're still not doing great a week or 2 or 3 later, maybe you do need more medicine. But because there's so much overlap in patients and because there's so much kind of difficulty teasing out what from what, that's not always possible or easy to do. And so I would say, again, we can wait longer, see if the urinary tract infection can get cleared before increasing or taking more medicine. But if it's not working, then more medicine is going to be the next step. And realistically, there's no black and white answer. It's not as black and white as everybody would think. Yes, it's positive. No, it's negative. There's a lot of kind of continuation or overlap or gray area here that makes it much more challenging. Maybe. Can therapy retrain the brain to use different pathways or signals, sort of like post-stroke treatments? Yes and no. So we have been trying to rewire and reprogram the brain for a long time. Um, this is the idea of physiotherapy or, using a bunch of different techniques, working on the mind-body connection. And physical therapy has done this too, again, in stroke patients, where you're trying to help other non-affected areas of the brain take over some of the control from the damaged area. We're not very good at it, in my opinion, but it is something that is being looked at and continually worked on. There are reports about this working, at least in some things. Physiotherapy, probably the way I describe it the best is if there's phantom limb pain. So if somebody has an amputation of a leg and then they have a lot of phantom limb pain, I don't know if you've ever seen them, they'll put a mirror in between to make them look like they have two legs, and they work on focusing on that connection between the pain signal that's getting to the brain and the reality of not having a leg. That's physiotherapy, where they're working on that brain body connection or brain nerve connection. And they have some success. There's plenty of reports of that being helpful and working on it. This is the same type of idea we use in functional neurological disorders, where there's not a specific structural problem or chemical problem, but there's a connection problem. And we do have some success doing these things. I don't know that we've ever done that in Parkinson's disease, where we can say that, hey, if your dopamine pathways aren't working, maybe we can, subvert to the acetylcholine pathways. And part of that is because your dopamine pathways are actually everywhere and control a whole lot of things. You would have to rewire basically the whole brain. We think about dopamine in Parkinson's disease as affecting movement, but it actually spreads to every part of the brain, and it actually controls a whole lot more than just that. And so while I think it's a good idea, and we should be looking at some of these things specifically in walking and balance, and I think they do this in terms of cognitive testing or dual task treatment or training, where they have you doing multiple things at one time to try to work on these pathways. I think it is hard, and so I think it's still a work in progress. But they do work on this, and there are some things that they can treat and try to do that with. When do I recommend a neuro-ophthalmologist? It's tough. Neuro-ophthalmologists are hard to find. And in my experience, they haven't necessarily been all that more effective or beneficial or helpful than just a good ophthalmologist. Now, neuro-ophthalmologists have more training in neurological disorders, so theoretically, they would be the ones who would be the most beneficial for people with neurological diseases or disorders. And you're not wrong. We have a couple here. There's a couple over at UPMC. They do good work. But my experience in my patients with Parkinson's disease, and this is my opinion, you can write this down as my opinion. My experience in my patients has been, if you have a good ophthalmologist, and this is different than an optometrist who just gives you glasses. This is an ophthalmologist, an MD or a DO, who can look in the back of your eyes and generally take care of the overall health of your eyes and vision. And you've been working with somebody who knows you, who's been seeing you for a while. stick with that person. I really have not found in my patients that, stopping seeing that person and going to a neuro-ophthalmologist has been all that helpful. There are some cases if you have a specifically challenging or odd ophthalmological problem, particularly a ophthalmological problem, then a neuro-ophthalmologist makes sense. But realistically, for my standard patients with Parkinson's disease, if you have a good eye doctor and they've done good work with you, stick with them. That's generally my opinion. Again, if it's not going well, then maybe you do need a new eye doctor, an ophthalmologist, or maybe even a neuro-ophthalmologist. Although I would not, if things aren't going well, I would not want you to wait 6 or 9 months or a year to get into a neuro-ophthalmologist if you can get into an ophthalmologist quicker. That would be my opinion. How often do my patients bring in the various symptom tracking forms or app results? Very rarely. Are they helpful? Yes, to some extent. Do they also help find things that may not be Parkinson's disease related? So they may be relevant to the proper refer to the proper specialist. Sort of. What suggestions are there for a patient that does not have a caregiver or advocate to notice things or write them down as if the patient is unable? All right. So there are a lot of apps out there, and there's a lot of symptom tracking forms where you can, you can do a Parkinson's disease diary where hour by hour you can put how your symptoms are, where you're at in your medications, what kind of problems you're having. It can be as detailed or undetailed as you want. And there are apps that can on your phone or on a smartwatch or something that can monitor tremor as well as steps and walking. And I think the iPhone does stride length or all kinds of walking parameters. Um, and so you can get as much information or as little information as you want. And that's only getting more and more as we get to artificial intelligence and more use of technology. This is only going to exponentially increase. But there is a problem with all that data. Somebody has to interpret it. And again, you don't get that much time with me. So I will glance at it, but thinking I'm going to go tease through days and days of hour by hour symptoms, that's just not feasible in the office. You can get them to me sooner, but at the end of the day, going through all of this information is tedious and time consuming. And that's just not feasible for day-to-day practice for your average neurologist or movement disorder specialist, just being honest with you. It's useful to pick up patterns. And so that's really what we're trying to figure out, right? We're trying to figure out, is there a pattern, particularly a pattern of difficulty or a pattern of problem that can be intervened on? And so there is some benefit to keeping track of these things, right? If you can pick up a pattern and you can bring to me and say, hey, my pills wear off after 4 hours, but I'm taking them 5 hours. And look, I can show you every time I hit that 4 hour mark, I'm stiffer, slower, and having walking problems. That's actionable. I can't fix that. I can treat that. I can hopefully do better with that by adjusting medicines or adding different things. And so there is a lot of benefit to at least keeping some track of your symptoms. Do you have to go all out and have fancy technology? No. Do you have to do line by line every minute of the day how you're feeling? Also, no. But is it useful if you can keep general ideas about things you're noticing, things that are going well, things that aren't going well? Yeah, those are really helpful. That's what I want when you come to my office, because that's what helps me figure out how to help you do better. And you can pick up other things. And so you can find, hey, I had this pain, or I felt my heart racing, or you can pick up other symptoms when you're paying attention and you're keeping track of these things, which in turn may lead me to referring you to other places. But the key to success is knowing yourself better than me. It's really knowing what your problems are, seeing if there's any patterns, particularly in relationship to medications, time of day, what you've been doing. And as succinctly as you can have that, by the time you hit my office, the more success we're going to have. If you're able to pick up patterns in your day-to-day life or in your night or day and night in terms of when you're feeling good, when you're feeling bad, was there something specific that triggered those? Be it your pills wearing off or overshooting or time of day or eating certain things or doing certain things, or if you miss sleep or if you're sick, these all are helpful in terms of, can we adjust things to see if we can get you doing better? Now, again, you can go as crazy and as detailed as you want, or as minimalistic and kind of more vague as you want. And yes, there's probably a happy middle ground there in terms of clinical practice and what we can and can't do. But to each their own. Luckily, I would say the majority of my patients do have a caregiver or advocate, but it is much, much harder when you're by yourself, especially if you have memory problems or physical problems where you can't write things down. Because I do tell my patients, make a list of things. If you want to make sure you don't forget to talk about something, the best way to do that is to write it on a list and make sure you bring it with you when you come to my office. And so it is much harder when you can't do that on your own or you don't have somebody who can help you. And I don't have a good answer or a good solution for that. You just have to do your best. If writing is a challenge, maybe you can use some dictation software. Again, if you just need more help or support, again, the foundation has useful resources. We can try to find people who can come in and help. But these are all things that we need to talk about and try to help figure out what the best plan is. The short answer is yes, there's a lot of different ways you can do this, and no one way is not better than another. But as much information as you can give me in more or less a succinct fashion, that's going to be the thing that helps me take the information from you, figure out what medically makes sense in terms of how can I work on this? How can I try to adjust something or change something to see if we can make this better so that when you come to my office in a very short amount of time, we can come up with a good plan to get you going in the right direction. $6,000 for the vibration gloves. That sounds like a whole lot of money to me, my opinion. Can Parkinson's disease affect breathing? Yep, you know the answer is going to be yes. And pretty much if you start the question with can Parkinson's disease ... the answer is almost always yes. And so it can actually affect breathing in a couple of ways. So one is you get stiff. Stiffness definitely makes mobility difficult and it makes breathing not usually incredibly hard, but it can restrict or limit breathing sometimes. Where I would say Parkinson's disease affects breathing the most, in my experience, is actually in the form of dyskinesia. As a side effect of the medicine. So the medicines can give you extra movements or squirmy movements. That's called a dyskinesia. But you can also get what's called a ventilatory dyskinesia. And so I get patients who come to my office who say, I feel extremely short of breath. I can't breathe. I have trouble catching my breath. My oxygen doesn't change. I've had it checked. My breathing, I'm getting enough air, but it feels like I can't breathe or I'm short of breath. That is usually the description of a ventilatory dyskinesia, and that's usually a side effect of the medicine. So I would immediately look at timing of medicine and how that relates. That's probably where I've seen it affect breathing the most, although it can definitely affect breathing in a lot of other ways. Again, the stiffness can affect breathing. Swallowing can affect breathing because you can aspirate or you can choke or you can, inhale liquid or food, can lead to pneumonia and things like that. There's a lot of different ways breathing is impacted in Parkinson's disease, but that's probably what I see the most. Do I recommend probiotics to people with help with constipation? I don't. It's a short answer. I've looked at some of the papers on the probiotics and the prebiotics in Parkinson's disease, and there's evidence there. I mean, don't get me wrong. We've been studying the GI tract for a long time. We know there's differences in gut bacteria. We know there's more bad specific strains of gut bacteria in people with Parkinson's disease. This is all fairly well known and proven. What I have yet to see is good evidence to suggest that a probiotic changes that. Again, there's one that's touted, and I can't remember what it's called, but I have patients that take it, and some of them say that they like it and that it helps. But I have a hard time kind of seeing the evidence to suggest that yes, we can pinpoint those bad strains of bacteria, we can correct that, and taking a probiotic actually corrects the gut flora to a more normal gut flora. I haven't seen that evidence. Logically, does it make sense? Yeah. I mean, there's definitely some logic there that, hey, if you take a probiotic or prebiotic and you're flooding your GI system with good bacteria, that over time that can take over and maybe repopulate your intestinal tract with good bacteria. I definitely think it's logical. I just haven't seen good evidence to suggest that that's what happens. Again, more to come. There also aren't a lot of good randomized, controlled, kind of gold standard research trials on probiotics, because again, nobody's going to spend money on that. Even the companies that sell it to you really have not done those types of trials. And so we're never going to have the gold standard evidence for it. But I'm also not against it if you want to take a probiotic. There's a difference between being okay with you taking it and recommending. I really reserve my recommendations for things that are well proven, have a lot of good trials behind them, so on and so forth. But if somebody comes to me and says, "Hey, I'm going to start a probiotic. What do you think?" I say, "Go for it." I think the risk is fairly low. Again, I don't think you're going to do a lot of damage with probiotic, prebiotic, a supplement, things like that. And the logic is there. It makes sense. Just because the evidence isn't there doesn't mean it doesn't work. It just means I can't recommend it. And so at the end of the day, if you want to try a probiotic, you are more than welcome to if you're my patient. And then let me know what happens. I'm always interested in hearing what happens when you do these things, because I get a lot of people that ask. This is true for every supplement out there, every vitamin out there, every over-the-counter thing out there. You're almost never going to get enough evidence for me to give a recommendation for it. But that doesn't mean I won't tell you what I think or what I've heard, or, hey, I just had a patient come back and tell me this worked. If you want to try it, go for it. That happens not infrequently. And so I'm always interested in what happens if you do try these things. You guys keep me more well informed than probably anybody, any drug company or any other thing does. And so keep telling me what happens and we go from there. Oh, Amanda wanted me to remind you that she does have journals in. I don't even know if I should say this. We have journals in my office if you do want to start keeping track of trends or using one of those symptom trackers, in terms of trying to see if there's any patterns in your day-to-day symptoms. Apparently, we have some in our office. We can get you hooked up with one if you want. What specific information am I looking for? I feel like I need a little bit more clarification on that, because that's a very open-ended question. Because I'm looking for all kinds of information. So if you want to type in what Dave specifically, what specific you're asking, I'd be more than happy to answer it. But the short answer to a very open-ended question is, I'm looking for any information I can get that is going to help me help you do better. I don't fix things. I feel like I'm always the bearer of bad news when people come to my office. They come to me because they've been told that, oh, Dr. Leichliter knows what he's doing. He's the expert, blah, all things you really shouldn't believe when you come to my office. Trust me. And then I feel like they're let down when I say, yeah, I don't really have a test for this. This is just what I think. I don't really have a fix for this. I feel like it's a big letdown when people come to my office and I tell them the truth, and that I don't really fix things. I'm not a fixer. I am a manager. And so I manage things. Okay, that's what I thought you meant, but I just wanted to clarify that question. So my job, my entire job, the reason they pay me is to help you do as well as you can, as long as we can, preferably on as little medicine as we can. That's the name of the game in my office. If you're my patient or if you're not, this is what I do when you come to my office. And I do that in a whole bunch of different ways. Most of what I do is listen. So again, you guys tell me 90% of what I need to know to help figure out what to do. The other 10% is what I find when I look at you. So I poke you, I prod you, I hit you with a hammer sometimes, I feel your arms and legs. I always make you do this kind of thing, which gets made fun of at every conference that we have by all the people who have Parkinson's disease. And then I have you walk up and down my hall, and I have you write your name, and I have you draw some spirals in my office. And people get tired of all the tests that I make them do every time they come back to my office. And that exam really gives me about, I would say, 10% of the information that I need. And the other 90% is really what you guys are telling me. And so I can't say that there's a specific information that I'm looking for. I need to know what's going on. I need to know how you're doing. I need to know what's going well. I need to know what's not going well. I need to know in particularly what is your absolute biggest problem, what is bothering you the most, what is keeping you from doing the things that you like, want, or need to do. That's where I get 90% of the things that are going to help me figure out what to do. It all comes from your guys' talking to me and me being able to listen and interpret what you're telling me. If we can get to the problem, if we can get to this is my biggest problem, this is what I want to work on, this is what keeps me from going out to the gym, this is what keeps me from going out to eat with my friends, this is what keeps me from going to see my grandson play baseball, this is what really irritates me. If we can distill all of your symptoms and all of the problems down to that major question, then the next step is what do we do about it? And so the specific information that I need is exactly that. What have you been doing? What's been going well? What have we done or changed that's helped? What have we done or changed that really didn't help? I put people on a lot of medicine, but that doesn't mean the medicines always work. Just because I have an idea, and of course I think it's a great idea, doesn't mean my ideas always work. And so if what I'm doing isn't working, I need to know that. I need to know what's going well. I need to know what's not going well. And I need to know what the biggest problem is. You may come in and I may see your hand shaking and I may say, ah, that's a problem. But if that's not a problem to you, it doesn't make sense for me to go trying to treat your tremor. If you come in with a tremor, but your biggest problem is that you have back pain and that's what's keeping you from going to your grandson's soccer game, I may say, hey, let's try more carbidopa, levodopa to see if I can get your tremor doing better. And I haven't solved a single thing. I have not done you a service. I haven't done me a service because you're going to call me and tell me that didn't work because I wasn't even close to what the biggest problem was. Really, I needed to send you for physical therapy so we could work on your back so we can get you doing better. And so you get the idea. The best thing you can do is tell me what the biggest problem is. It may not even be related to something I take care of, and that's fine too. You may come in and say your urinary problems are your biggest issue. And maybe I know how to manage some, but maybe I need to get you to a urologist. Or you may come in and say, you know what, I'm just severely depressed. I have no energy or no desire to do anything. And I'd say, okay, we need to work on that. Yes, you're stiff and you're shaky, but if that's your biggest problem, let's get you to a psychiatrist and work on this. And so when you're asking what specific information do I need from a patient to help me treat them, it's what's going on and what's the biggest problem. That's really going to help us have the most success to figure out how we correct that problem. Again, it's not up to me to tell you what I think your biggest problem is. That's silly. I should not be the one telling you this is your biggest issue. And I certainly don't want to treat whatever I think is the biggest issue. My opinion doesn't really matter in this game. What matters is that I can get to the bottom of what's keeping you from doing the things you want to do, and then I can figure out how to work on that. And that's really the best. And if that comes in a diary or a symptom tracker or an app, or if that just comes from your experience and you can just sit there and tell me what the problems are, it doesn't matter how you relay that information to me. It really is, as long as you can get that information to me, then we can come up with a plan together. A lot of times the plan is more medicine, right? That's probably my most commonly used tool. But that's not always the best choice. Physical therapy might be the best choice. Maybe deep brain stimulator is the best choice. Maybe getting you to another specialist is the best choice. But again, if you're leaving it up to my devices to try to figure out what your biggest problem is, that's not usually a good way to do it. And so as clearly as you can kind of relay that information is going to be the thing that helps the best. I ran out of questions, Casey. I guess I should be done. I finished 3 minutes early, which is very unusual for me.
Yeah,
I
that's
guess
great.
we'll just call it I'll give you 3 extra minutes to tell us what's going
Okay,
on in the Parkinson's world.
great. Well, we have a Medicare webinar tomorrow at noon, and also our last webinar of the year on Tuesday at noon on medical marijuana. And let's see what else. Our regular offerings. I think that's
And then
it.
I guess our next talk is,
Oh,
would you tell me
yes,
it was
yes.
December
Karen,
5th?
thank you so much. Yes, December 5th. So our last talk with the doc is on December 5th at 4:45 p.m. Let's see. I think that's it.
Perfect. All right. Well, you guys have a good month. Have a good Thanksgiving. And I'll see you back in December and we'll talk
Oh,
again.
yes. Thank you. And a different Karen mentioned that she really liked how you summarized in the last 5 minutes. So
Glad
that's
I could help.
recommended for future sessions. We'll keep it going. Have a
Perfect.
nice
Thanks, guys.
Thanksgiving, everyone. We'll see you on December 5th at 4:45 p.m. Thank you, Dr. Licklider. Thanks, everyone.
No
Bye.
problem.